Merhabalar, hepiniz hoş geldiniz.
Hello everyone, welcome. After Erol and Murat, I will be talking about a different topic. Actually, Jakub had a transition kind of speech, but he's not with us. I'll be talking about untreated depression, which is resistant against treatment. In some people, it is an acute and treatable disorder, but in some other people, it is chronic and recurrent, and it is not responding to treatment. So, treatment is depression which is resisting against treatment is a very much used definition for the major depressive disordered people, and of course it is increasing but the cost in terms of cost of treatment and also the quality of life. When we talk about major depression population, we can see 10 to 15% prevalence, and it distorts the function of the people. In spite of all the developments in psychopharmacology and biomarkers, and in spite of the antidepressants having side effects mechanisms, there is a response of 60 to 70% of the patients to the treatment, and 10 to 30% of the patients who do not give response to treatment are accepted as refractory or resistant responder groups. So response is generally decided if it is less than 50% at HDRS score, and remission at least requires a symptomatic situation at least for 2 weeks, and recovery is this remission for 6 months. Generally in the clinic we use Hamilton HRSD when it is below 7. We want it to be lower than 7, and this is the way how we want to follow it. So in the books or in the other articles we see this very frequently. This is related to depression, or it can be attributed to other diseases. This is the 5 R's of depression. So there is at the acute phase response. After seeing 50% of response, we get to remission stage. After remission, for 6 months of period, there comes a recovery. So during that 6 months, if patient gets aggregated, if there's flare-up again, it is called as relapse. If after recovery the findings and symptoms of the disease emerge again, it is called as recurrence. And pseudo-resistance, also this is actually a wrongful diagnosis. It could be bipolar depression or psychotic featured depression, and there could be certain differences of clinicians' perspective. So we might say schizophrenia, but you might say something else. It could be diagnosed depression. And comorbidities are also very important. These are the physical and medical conditions. Comorbidity, and also there could be insufficient treatment period and dosage, heterogeneity of the patient and incompliance of the patient to the treatment, and decompliance, detolerance, and pharmacokinetic interactions. These are very important. When we talk about resistance against treatment, we have to be talking about STAR-D treatment. It is from the United States, including more than 4,000 major depressed persons, non-psychotic ones. In the first treatment tier, there is 3,671 patients, and in the fourth one there is 123 patients. So the ones who couldn't tolerate the treatment and reach into remission are sent to the next stage, and the ones who are at the remission have been analyzed on the 12-month naturalistic phase, and quiz is also filled in by the patients. And here you can see this is enrollment, and stelopram and SSRIs are used. It doesn't have to be from the other antidepressant groups. And on the third phase you can see tricyclics and lithium and mentation, and on the last side you can see metazapine combination. On the study, when you look at the remission rates, in the first step it is 37%, in the second step it is 30%, and here you can see there is the primary resistance here, and in the third step you can see 14% of resistance. We see resistance here very clearly, and on the fourth step there is 13% of remission, and cumulative remission rate is 67%. On the study, these are the prioritized things. so the efficiency of the treatment is lower than the expected one, and different treatment strategies are needed because of the non-respondence of the patients to the treatment, and chronic and recurrent depressive episodes require different strategies, and long-term results are worse. And after 2 different treatment strategy application, cumulative remission rate becomes 50%, and in the inpatient units, the resistance against treatment is higher. Of course, the follow-up period after the treatment is very important, because in the first couple of months, it is the risky period for relapse. SARD has certain restrictions. QIDS is used as a self-report, and it is not designed on a blind manner, and I think it's affected by the design. I mean, the results are affected by the design, and antipsychotic enhancement is not given, and placebo controlled arm is not enrolled into the study, and generally dosages are higher than the normal practical dosages. So these are the precursors of the refractory treatments. HPA excess impairments and inflammatory system activity increase, hippocampal volume decrease, and BDNF and NTRK2 interactions, and gene and environment interaction. So these are some of the precursors of the resistance. So early onset of the diagnosis, and more frequent and recurrent episodes, longer period of disorder, and aggravated, augmented severe disease, and also suicidal history after the previous depression episode, not having partial remission or non-remission. These are some of the precursors of the resistant treatment. And there are certain accompanying anxiety disorders. There are some other medical disorders as well. Conceptualization and staging models of the refractory depression. There are 5 models that I have found. However, generally there is 2 different antidepressants treatment. If there is no clinically significant recovery, it means that it is a resistant depression. After stage 3, tricyclics are added, and MAO inhibitors are added at the stage 4, and AKT are also added at the stage 5. There are restrictions, as I've stated beforehand. So here, Taze and Rush has a certain algorithms. MAOs are better than tricyclics, and tricyclics are better than SSRI. And it is related to, they haven't made any statements about the dosage and the duration of the treatment. It is from Massachusetts Hospital. It is about staging. There are certain scores and points used for treatments. Each and every treatment there comes 1 point, optimization, augmentation. For combination, there is 0.5 points. For EKT, there is 3 points. Of course, the higher the score is, the higher the resistance is. However, there is a problem about the scientific reference of the design. Why do we give 3 to AKT and 0.5 to augmentation, for instance? On the European staging method, it is based on the duration of the chronic resistant depression. So there is 2 different stages. After 12 months, we can talk about chronic resistance. And minimum and failed treatment number must be defined. This is much closer to the literature. The severity of the symptom and the recommendations for the treatment have not been placed, so this is the weak side of the method. Maudsley has a staging method. It is related to the duration and also a symptom severity and failed treatments, unsuccessful treatments. So in total it must be 15. So the higher, the more resistant. And the resistance of the treatments must be evaluated based on multi-factors, and it has also been supported by some other trials that it has a good projection and estimation value. This is from Australian group. It is about the clinical staging of the disease. There are certain biological markers here. Each and every stages matched with biological markers, and progression is staged. As I've stated, biomarkers are included, and for each and every stage, interventions are recommended. Depression stage might give us a chance to provide a more systematic treatment option like we have in the cancer or other infectious diseases. This is the more comprehensive one, as far as I can see. Kone et al. Has another two-step model. It is for the first stage. You can see it is less invasive treatment methods recommended, and in this second stage, 3 antidepressants or psychotherapy combination. If it is not sufficient, then more invasive treatment models are recommended. So if we want to treat a patient, if you want to accept a treatment as an unsuccessful one, first and foremost, we have to be following the patient's treatment, whether he or she is complying with the dosages and the usage of the drugs, and also sessions are needed. At least 8 sessions must be started. Intolerability should not be accepted as a failure for the treatment. So in the resistance against treatment, there are 5 main strategies. On optimization of the antidepressant, switching, combination, augmentation, and somatic treatments. So optimization of the antidepressant, it is actually about the enough dosage and enough time. It could be actually 12 weeks in certain periods. And switching is from a different group to a different groups, or from the same group, SSRIs to SSRIs, or different groups to other groups, for instance. They are open trials, they are not controlled trials, and the response rates here are very changing. So changing SSRIs, switching from one SSRI to another SSRI might not sound very well in the first sense, but for instance, Ciploram to Strolan shows the same efficiency. So from the first degree SSRI to another degree of SSRI, switch is possible, and there are also TCA-related studies. If depression is attributed to melancholy, TCAs are superior to depressants, but TCAs are not very much up to date right now. So SNRI, mitriptyline, and MAO inhibitors, bupropion, these are also experienced by us, but there are not many outstanding and striking findings about them. Combination strategies are very much used in our clinics, but they have certain problems. They don't have too big confidence on the proof levels. Augmentation, I'm going to be talking about that. So another second agent could be added to the treatment, which is not antidepressant. For instance, antipsychotics could be added. I will start with antipsychotics first. 16 trials, placebo-controlled ones, with antipsychotics. As a result of these 16 trials, authors said that we do have some odd ratios, good or bad. For all antipsychotics, we have a certain interval, and odd ratio is provided. So these are placebo-controlled, very safe and big trials, and it is effective for the treatment-resistant major depression. And aripiprazole, you can see psychomotor retarded depression. Quetiapine could be given with the anxiety accompanying depression with very lower dosages. But in the long term of usage antipsychotics, there could be neuroendocrine and metabolic syndrome. So in the long term usage, there could be certain problems. So augmentation with lithium. Prior to 2000 trials, 3 of them have been found superior to placebo. However, the duration of the trials are very, very low. So 2 days, 2 weeks, and 3 weeks, you can see. They are not very long-term studies. Generally, lithium is given between 600 to 1,200 milligram per day, and odds ratio is 3.31. It seems more effective than antipsychotics, but you know that authors are always criticizing one another, and they say that in your previous controlled studies, you also showed no effect. However, antipsychotics, either good or bad, we have always seen effects, and lithium, in addition to all these statements, do not have any trials with new antidepressants, and toxicity and blood monitorization is needed, they say. And in the T3, there are many other trials which are similar to lithium, so 25 to 50 milligram per day, and they are tricyclic and they are added to TCAs, but STAR-D level 3. Here you can see lithium's and 3D augmentation is compared, and after STAR-D, certain results have been reflected on the usage. I mean, T3 seems higher on the remission, but there is no significant difference. And on the discontinuation, T3 compared to lithium is much more advantageous. So lithium can be stopped easily compared to the T3. Augmentation with buspirone, STAR-D level 2, there is 31%, but pidolol, testosterone, omega-3 fatty acids, dopamine agonists, and there are not many studies about. There are many studies about them. However, we need more placebo-controlled trials. Yes, in certain reviews, good proof levels and efficiency are mentioned. In certain trials, lithium and T3s are effective, but certain US studies show that antipsychotics are much more effective, but inositol, estrogen, omega-3 are not very much supported, and herbal supplements and lamotrigine, they don't have any proof. If I'm to talk about somatic treatments, in the treatment-resistant depression, there is still 50 to 70% in the AKTs, but here in the AKTs, that well-being feeling cannot be sustained. For that reason, it must be supported with other additional treatments and other somatic treatments, RTMS, VNS, FDA approved treatments, and also transcranial direct current application. Are they really effective? Are they really reliable? Even if they are effective, there are certain question marks on the minds of the people. Psychotherapy is effective on the mild and moderate depression. If it is a severe depression, with psychotherapies, antidepressants must be combined, especially cognitive behavioral therapies efficiency has been improved. And I will be talking about new treatment options. Ketamine is the NMDA agonist, and it has a great antidepressant effect within months, within hours, or within a day, and its efficacy lasts for 7 days. And esketamine is ketamine as enantiomer. It can be used nasally, and it was given FDA approval a month ago. This is related to esketamine. It is especially with respect to treatment-resistant depression. It has 2 phases, and 67 patients were enrolled, and 33 on the placebo arm, 34 on the esketamine arm. It is double-blind, and in the second part, in the second phase, the placebo arms again are randomized, and for 75 days open label study was conducted. So the interesting thing is that esketamine efficiency cannot be seen in the long run. We had that opinion beforehand, but at the end of the trial, where there is esketamine, it is given 2 times a week, but then it is given once a week, and efficiency has been approved that it's still valid at the days of 75. And rapastinel is the partial agonist. It is a breakthrough drug. Phase 3 program is still carried out. It is it doesn't have any dissociative side effects. NMDA antagonists, we can talk about lenisamine, and so there are certain other topics on immune system, because this is a chronic inflammatory process. So interleukins and TNF-alpha, CRP, and MCP1 are always mentioned. Anti-inflammatory markers are evaluated in many trials. Celecoxib, infliximab can be promising for the treatment options for the future. And tricyclics, maybe we can go back to serotonin dopamine reuptake inhibitors could be developed, and we can go back to tricyclics. We can also increase BDNF. There are certain treatments to be developed in order to increase BDNF, and buprenorphine could be used for the treatment-resistant depression. There are certain trials going on in this areas. So response rates in the treatment-resistant group, and treatments like non-pharmacological ones have been recently defined, but these non-pharmacological treatments, continuity and sustainability is still doubtful. So we need to find more proofs to be able to say something certain. And acute treatments can only be accepted if remission is reached, because if remission is not reached within a certain period of time, then it means that it is treatment resistance. Of course, family history and anamnesis is very important in the first resistance. AKT and also antipsychotics and other augmentation strategies addition could be very appropriate. We should not be waiting for the last stage. Major depressed patients, 70% are responders to the treatment, 30% are accepted as the resistant ones to the treatment, 25% could be used for optimization and combination, 50% could get benefit from switching, and 25% of them could be our target for augmentation. So treatment-resistant depression, each and every individual must be evaluated based on their own features, and psychoresistance should be excluded, and also appropriate treatment must be preferred. Neo-drug psychotherapy and somatic treatment methods are needed with randomized controlled trials. Thank you very much for your attention.